Today, I have the privilege of welcoming Dr. Gavin Oudit, a distinguished professor, staff cardiologist, and clinician scientist at the University of Alberta. With his expertise in heart failure, cardiomyopathies, and the impact of COVID-19 on the cardiovascular system, Dr. Oudit's insights promise to shed light on the intricate relationship between Fabry disease and cardiac health. Hi, Dr. Oudit.
Hi, Julia. Good morning. Great to be here.
Yes, great to have you here. We have a big topic to cover today because understanding the complexities of Fabry disease and its impact on the heart is crucial. So, the goal of this conversation is to break down the complexity and simplify it a little bit so our listeners can really comprehend what's happening to the heart. So, let's start really broad. How is the heart affected in Fabry disease?
Yeah, no, absolutely. So, Fabry's disease is a metabolic disorder due to a genetic change that leads to accumulation of a particular molecule, a sphingolipid, um, that accumulates in the lysosomes. So these are intracellular storage granules that process these things in cells. And so because of this genetic change, this lipid accumulates in these lysosomes in cells. And so it affects many different types of cells in the body, but the cardiovascular system is particularly affected. In fact, the blood vessels, the inner lining of blood vessels, the endothelial cells, are the earliest cells to be affected with Fabry's disease. So it starts off initially as a vascular endothelial disease, and then it progresses into multi-organ involvement. And the heart is one of the key organs that is affected with Fabry's disease. Over the last few decades, heart disease has now become the number one cause of mortality in patients with Fabry's disease because we have become better at managing some of the other manifestations.
And do you find there is a different the way that males and females present cardiac
Yeah, no,
manifestations?
absolutely. So the gene that affects this alpha galactosidase, and it's X-linked. So women have two copies of that gene. Men have only one copy because men have an X and Y. Women have two X's. So men typically are affected more severely, and they're affected earlier with the disease. So earlier onset and a more severe disease. Women are affected, and in fact, because of the Lyon's hypothesis, one of the X chromosome gets randomly inactivated, and if your normal um, gene is inactivated, then the mutated gene and the other X chromosome takes over. So the disease manifestation in women can also be quite severe. So there is clearly a gender difference, sex difference in Fabry's disease, and that needs to be recognized at multiple levels. One, of course, is the severity of presentation, which is different, age of onset of presentation, which is different. So clearly, earlier onset of disease in men and more severe disease, but also in terms of diagnosis. So this is important because the biochemical test, the alpha galactosidase activity, is low in men with Fabry's disease, but it's relatively low normal in women with Fabry's disease. So that biochemical test can't be used in women for a diagnosis of Fabry's disease. So this is where we'll turn to our fancy genetics, and genetic testing is what's indicated, of course, for men with Fabry's disease, so we can pinpoint what the exact genetic change is, but also it's absolutely compulsory in women to make that diagnosis to be able to pinpoint the genetic change that's leading to Fabry's disease.
What would you say the first symptoms are that patients are
Yeah.
experiencing for that the first cardiac
Yeah, so
manifestations?
there are two major versions of Fabry's disease: the classic and the non-classic, or the variant version. So the classic is what typically starts as in children, and it's the acroparesthesia, the burning sensation in the hands and feet, and some of the the gastrointestinal symptoms, some of the ringing in the ears, hearing loss, and so on are some of the earlier manifestations. Um, in patients with classic Fabry diseases and in patients with non-classic Fabry disease, heart disease obviously starts probably at a fairly early age. So we
Okay.
have to remember that when patients come and see us and complain about com- uh, heart-related symptoms, they probably already have had significant damage to the heart, probably for at least several decades. So some of the manifestations that heart disease might lead to is things like poor exercise tolerance, so dyspnea, shortness of breath and exertion, feeling lightheaded, maybe even having a blackout spell. Um, those would be
Okay.
two common one. The third more common one, and we're seeing this more and more now, is chest pain. Uh,
Hmm.
Often, thinking that these patients are having myocardial infarction, but in fact, what they're having is very small myocardial infarction because of all the microvascular and all the endothelial cells that are affected. So those would be the dominant cardiac presentation symptoms that our patients would complain of.
Bradycardia. That seems to be a common one as well. So that's a low heart
Right.
rate.
And absolutely. And so with Fabry's disease, because of this lipid accumulation in the heart, it's what we call it infiltrative
Mhm.
cardiomyopathy. So it's where things accumulate in the heart. And and when that happens, it happens in Fabry's disease. Obviously, it happens in other types of infiltrative cardiomyopathies. The conduction system, which is the electrical wiring in the heart, is actually quite sensitive to this. And you can start knocking, impairing or reducing the ability of the heart to maintain normal electrical activity. So the two dominant presentation electrical problems with the heart in Fabry's disease is bradycardia, and often not being able to increase your heart rate with exercise, which is a normal response, and then with that is often associated with conduction problems. So it's when the
Okay.
electrical wiring now starts to get faulty and you start having conduction problems, and a significant number of patients are requiring pacemakers for that. So providing external stimulus to keep the heart going.
Right. And so when a patient reaches the point of needing an ICD, a pacemaker, or both together, that's a sign that the heart needs then a little extra support. And that feels a little scary to me. And I think that feels a little scary to patients when they hear that.
Right.
So, what would you say to a patient who's feeling a little bit nervous about
Yeah,
that?
no, absolutely. I mean, I think ideally we would like to have detect Fabry's disease way before our patients present with conduction problems, needing a pacemaker or even ventricular arrhythmias, or at risk for ventricular arrhythmias, needing a dual chamber ICD defibrillator. So at that stage, it would be quite late in the disease. So it's something that at that stage we have to expedite their diagnosis and care, and that includes, of course, putting in a device, but also medications to treat other comorbidities, and then starting Fabry specific therapies. So yeah, I think for Fabry's disease, but for other types of cardiomyopathies, the earlier you make the diagnosis, the earlier you can start intervention, including controlling risk factors, but also implementing specific therapies for the various types of cardiomyopathies, the better off patients are. We're seeing this more and more. So it really speaks to awareness of Fabry's disease, being able to
Mhm.
detect it early, and screening family members, cascade screening. So for every patient that we identify, we typically pick up anywhere from 3 to 5 family members that are affected with Fabry's disease. This really goes for all genetic disorders affecting the heart. So I think just that awareness and being able to think about Fabry's disease and making an early diagnosis is so important.
Absolutely. Because if you were someone who was reaching the point of needing a pacemaker or ICD, is it better to um, wait a little bit or I guess is it you placing more burden on the heart to yeah, by waiting that out? Or is that What are your thoughts on that if a patient's reaching that
Yeah, no,
point?
absolutely. I think if you're at a point of needing a pacemaker or an ICD, you clearly have fairly advanced heart disease. And so absolutely. So we would have that device implanted as soon as possible, and start therapies for risk factors for heart failure, um, but also Fabry specific therapies. But we really want to get to patients much, much earlier than that. The fact that if you're
Yes.
presenting at a point where you're needing a pacemaker, you would have had Fabry's disease for at least several decades, I would think, before we actually saw a patient last year that presented in the 60s with
Okay.
presyncope and very advanced conduction disease, and needed a pacemaker. But then in retrospect, we diagnosed him with Fabry's disease. But in retrospect, we went back and screened and did a family history and screened his family. And, he lost his brother to sudden cardiac death and a cardiomyopathy. And his aunt has now been diagnosed with a cardiomyopathy from Fabry's disease. So, very unfortunate case. He has family members across Canada, and obviously have lost a few family members to Fabry's disease due to this delay in presentation. And he actually presented with severe conduction disease and a blackout spell, and needed an urgent pacemaker. We started therapies, including Fabry-specific therapy, but clearly he was very, very late in his presentation.
Yeah, and as far as screening, we obviously have a lot of cardiac tests that we do. So our Holter
Right.
monitor, EKG, echo, and an
Yes.
MRI. And that so doing those tests and having those and keeping up with those tests, we actually just did a great podcast with Kayla
Uh-huh.
Moyne about why we have so many tests and why they're so
Right.
important. Can you briefly speak about the cardiac tests that we do and what you're looking for?
Absolutely. So when we assess the um, when we assess the heart, there are really two for Fabry's disease. There are two major things we want to look at: the electrical activity and then the pumping
Okay.
mechanical activity. The electrical activity is your 12 lead ECG, your Holter monitor. So they will tell you about conduction problems, low heart rate, bradyarrhythmias, tachyarrhythmias. So those are critical for any type of heart disease. The other piece is how the heart is working, what's going on with the muscle, and how the heart is working. And so echocardiogram is important because it's so widely available, and it does give you useful insight into structure and function. Um, but the test that's most helpful in terms of assessing heart structure and function is a cardiac MRI. Cardiac MRI is available in a lot of cardiac centers, often the specialized centers, but it can be limited. So that's a challenge. But a cardiac MRI will tell us about the muscle thickness, how well it's working, fibrosis, which is one of the manifestation of Fabry's disease, and it's often linked to conduction disease, because fibrosis are basically these blocks, these insulator blocks that gets deposited into the heart, and therefore electrical
Okay.
activity doesn't work well. So the cardiac MRI also provides a unique signal that we can measure, called a T1 mapping, that correlates very well with Fabry's disease. So we can not only diagnose Fabry's disease with T1 mapping, but we can also track um, and follow our patients with Fabry's disease using this technique.
I think that we touched on this briefly on a previous podcast, but what comes first, fibrosis or LVH? And is it a difference between male and female?
Yes, yes, yes. There is clearly a sex difference here. So men typically would develop hypertrophy, and then the fibrosis follow. In women, it's different. Where you can get minimal or no hypertrophy, but fibrosis starting early. So it speaks to sex differences in heart disease, and Fabry's disease is obviously one example of that. That's clearly has a genetic basis, but also modulated by things like gonadal steroids, estrogens, and androgens, and so on. So that's clearly an important difference. And in the test to sort that out is, of course, a cardiac MRI with
Okay.
and in fact, in women, fibrosis is one of the criterion that can be used to start Fabry specific therapies. So we have
Right.
adjusted, the community has adjusted how we approach therapies for Fabry's disease, and fibrose by itself now in women can be used as one of the criterion to initiate Fabry specific therapies.
So patients listening, very important to get those cardiac MRIs.
Right, and
Yeah.
it may take a referral to do that, but
Yes.
I think there is enough centers here in Canada that have cardiac MRI, and yeah, and I'm happy to say the protocol for that T1 mapping here was written here in Edmonton, and is now shared globally and all Siemens MRI systems. So it's a test that it's easily performed. So
Yeah. And when you're getting that, make sure to get the gadolinium contrast, of course.
right, and that piece detects the fibrosis. Yeah, the
Okay.
T1 mapping will tell you about how much lipid is accumulating in the heart.
Okay.
The gadolinium contrast will tell you how much fibrosis there is in the heart.
Okay.
Then, I think so many of our patients bring this up, not only with Fabry's disease, but patients with other types of cardiomyopathies and so on, right?
Yeah.
How do you, the challenges of living with it and dealing with it, right? And, fighting it, right? I mean,
Yeah.
so many of our patients talk about being fighters, right? So
Yeah.
yeah, I mean, I think you've touched on a few of the things you can do. Healthy lifestyle, eating healthy,
Okay.
exercising, so important, right? So those are important lifestyle changes. Obviously, non being a non-smoker. Fabry's disease is a vascular disease. That's a big one. And then therapies for Fabry's disease, right? So treating dyslipidemia, treating high blood pressure, which we know are major modifiers of Fabry's disease. So those would be things that can be done from a patient perspective. Obviously, there's Fabry specific therapies. I mean, it's a bit cumbersome right now with ERT and with megalostat, but I think hopefully with an oral medication, the substrate reduction therapy, that might be a game changer. So we're seeing, and that's again progress, right? There's now a new molecule on being tested, phase 3 trial already. So
Yeah.
good biomarker results with it. So we'll see where it goes in terms of helping the heart. So
So things we can do to protect our heart include exercise,
right,
not smoking,
right,
a good diet.
right. Those would be, yeah. I mean, those would be the three main things to do. Um, and then of course, I mean, taking your medications regularly, um, and being involved, right? I mean, this sort of stuff. The psychological aspect of dealing with,
Mhm.
patient advocacy, talking to other patients, helping other patients.
Right. Getting that support can
Right,
also
right.
bring down those cortisol levels and help with that stress
Oh,
management.
well, absolutely. And I think I sent you two emails in the last 6 months, right, with two patients.
Yes.
Yeah, that were affected with Fabry's disease, and so both patients were, they have children, they have, and sons, daughters, and they're concerned, right? So I think some of their children are likely affected with Fabry's disease, and so I mean that's you see that part of it too, right? You see that guilt that comes from being a parent, and having, passing it on to children. So it's great for them to it's great for patients to connect and talk about that.
For sure. You need community to
Right,
sort through some of those things.
right.
Absolutely.
Yeah, yeah. So
Now, do you have any research you'd like to share with our audience?
yeah, no, absolutely. Thanks to all our patients' involvement with our in our clinics, but also being part of our research program, we're doing a lot of exciting things, and a lot of this we have published on. But our ongoing effort is what something we've talked about, the importance of screening for Fabry disease, the so importance of early diagnosis and changing the trajectory of the disease with early diagnosis. So we are looking at screening in patients with undiagnosed LVH, and we have picked up 3 patients so far with Fabry
Okay.
disease as part of our screening protocol, where we continue to do this. And so basically, the prevalence of this from our study and in combination with other studies, about 1 to 2% of patients with LVH, concentric LVH in particular, would have Fabry disease. So that's a significant percentage of patients, and then of course has
Absolutely.
huge implications for all the family members, right? So it's just a cascade. Hence the term cascade screening. So that's one of our big projects. We're also looking at biomarkers. We
Okay.
talked about early things that can change in the heart that we can pick up with a blood sample to be able to guide us to assess heart disease a bit better and to be able to follow and treat things a bit more appropriately. Um, we've also lucky to be involved in a randomized control trial looking at Venglustat, so substrate reduction therapy for Fabry disease. And I'm happy to say we have enrolled our first patient in this.
Oh,
So this is
wonderful.
yeah, thank you. And so this is a very exciting therapy that tackles the disease very upstream, that hope to reduce the production of the glycosphingolipid in cells. So we're excited to be part of that, and we will see where the trial results go. But it's again another approach at tackling Fabry disease. And I just want to say how wonderful this is, because Fabry disease is really nicely illustrates the impact of medicine and progress, right? 4 or 5 decades ago, we really had no therapies,
Yeah.
and now we have enzyme replacement therapy, chaperone therapy, and possibly substrate reduction therapy. So, in addition to all the other types of things we do, like device therapies, controlling risk factors, and so on. So, it's a very exciting time for Fabry disease. There's been lots of progress, and it's a great honor to be seeing our patients and to be able to take care of our patients. So there've been it's been a great relationship, not only to understand Fabry disease and to treat our patients, but also to make progress.
Yeah, absolutely. And I think when we're in places like the World Symposium, it is amazing to look around and to see what's happening and what's taking place. And it's very encouraging. I don't think there's ever a great time to have a rare disease, but there is something to be said that when we look back, there wasn't therapy at all. And so we are in a different point now where there's more hope, and that's really important. And thank you for all you do, because you're moving the needle as well, and that's making a difference.
Oh, thank you, Julia, and thank you for being such a great advocate for Fabry disease and for our patients and for our community. It's really motivating, inspiring to see
Thank
what you
you.
do and to see how involved our patients are. No, you're absolutely to your point. Rare diseases, therapies for rare diseases are just exploding. I mean,
Mhm.
there are new things, and it just goes back to science and our humanity will lead the way, right?
That's right. Yeah.
Yes, and I think Fabry's disease, rare diseases, and even some of the more common diseases, now we're seeing this really taking hold.
Now, is there one final message that you want patients to know and to walk away with?
Well, we have moved the pendulum of Fabry's disease from being a terrible, untreatable disease to now a condition that can be diagnosed, be treated very fairly effectively, and patients are now living with Fabry's disease rather than dying from Fabry's disease. So it's great to see that trajectory. It is clearly more work to be done, and it's great that we're all connected and involved, and we'll keep making moving forward.
Yes, we will.
Okay.
Thank you very much, Dr. Oudit, for your time, your expertise. We are immensely grateful for you. And thank you for joining us on the podcast today.
Wonderful to be here. Okay. Talk to you again.
Take care.
Okay. Take care, everybody. Okay. Bye bye.
Take care.